بسم الله الرحمن الرحيم. محاضرة اليوم هي تكملة ما بدأناه بالمحاضرة السابقة عن oral malignancy part 1. Now we start with the oral malignancy part 2. We have the first, the carcinoma of the gingiva. Of all malignant tumor in the body, 3 squamous cell carcinoma is common. 3 clinical features as exophytic, irregular growth, ulcerative flat erosive lesion, and 3 symptomless initially then painful, and 3 invaded the bone due to its direct contact of the gingiva to the periosteum of alveolar process. This figure shows the erosive type of the gingiva and tibial side and lingual side of the jaw. The carcinoma of the floor of the mouth is usually atypical malignant ulcer extending to the alveolar process and the tongue. This figure shows the big ulceration of the floor of mouth that extending to the periosteum of the lower jaw and to the base of the tongue. The cheek is often warty and proliferative due to denture irritation and where the teeth are present from periodontal abscess. This irritation of the buccal mucosa that leads to leukophilic lesion of the cheek. This big mass is carcinoma of the buccal mucosa. The carcinoma of the heart pellets is often papillary or ulcerative and usually spread extensively before it affects the bone. It's difficult to distinguish it from carcinoma of maxillary sinus, which spread to the pellet. So it's very difficult to differentiate it between the carcinoma of the mucosa of the heart pellet or the carcinoma of maxillary sinus. The carcinoma of the soft pellet and focus are proliferative, fungating tumor and its poor prognosis due to spread to the base of the tongue and early involvement of the lymph node bilaterally. However, the soft pellet is not visual by the patient, so it is bad prognosis due to its spread of the tumor to the lymph node bilaterally and go to the deep lymph node, and it is big metastasis and lead to death. The symptom secondary infection cause pain and dysphagia, and death frequently occur following erosion of the carotid artery, and mainly in the floor of the mouth or in the mandible or base of the tongue. This figure shows the different side of the proliferative of mucosa of the cheek at the corner of the upper and lower lip, or in the gingiva of lower teeth, or in the floor of mouth, and the last figure, the erosive type of the mucosa that lead to squamous cell carcinoma. This figure shows the very big mass of the lower lip as exophytic mass growth, severe growth, or there are as redness in the soft pellet, or the change in color of the buccal mucosa, or ulcerative type in the retromolar area. This figure shows the different side of the malignancy in the ventral surface of the tongue, or in the heart pellet, or as a mass in the heart pellet. Now we go to the carcinoma of maxillary antrum. The squamous cell carcinoma, about 90 to 95% of the antral malignancies. The tumor infiltrates the soft tissue, destroy bone, and can ulcerate it into the mouth, pharynx, skin, or the face. The lymphatic metastasis to upper deep cervical node and rarely spread to retropharyngeal region. If teeth are present in relation to the floor of the sinus, they may become loose, painful, and periostatic, and may appear as acute alveolar abscess, the anesthesia of the cheek, or paresthesia of the palate. If nasolacrimal duct is occluded, epiphoria will ensue that lead to tearing that go outside of the nasolacrimal duct. If lesion has invaded the eye, propotos would interfere with one or more of the intraorbital muscle or the nerve supply, so lead to strabism, limitation of ocular movement, and diplopia. The nostril on the affected side may be blocked and blood-stained discharge pus from the nostril. Pain due to a secondary sinusitis. Trismus may occur due to the encouragement upon the middle pterygoid muscle. Now go to the other type of malignancy is malignant melanoma. Malignant melanoma is a rare condition more frequently in male and about 75% of patients and are 40 years of age or over. If present as raised, soft, vascular, dark brown or black mass, bleeding and ulceration are common. When occur in mouth, it destroys adjacent bone and loosens teeth and may invade blood vessel and lymph channel, and about 50% shows involvement lymph node. Now we go to the management of oral malignancy. We start from the diagnosis and then treatment of oral malignancy. The diagnosis of oral malignancy, clinical examination of mouth and throat for red or white patches, lump, swelling, or other problem as ulceration or destruction of the bone. This exam includes looking carefully at the roof of the mouth, back of the throat, and inside of cheeks and lip. Gently pulse out the tongue so it can be checked on the side and underneath of the tongue. The floor of mouth and lymph node in the neck also check if a suspected oral malignancy. The investigation includes to the diagnosis of oral malignancy. First, an X-ray of entire mouth can show whether malignancy has spread to the jaw. We take chest X-ray and other bone radiographs to establish secondary metastasis to the bone. We take CT scan and an injection of the dye tumor in the mouth, throat, neck, or elsewhere the body shows up on the CT scan. Magnetic resonance image can show whether oral malignancy has spreading or metastasis to the soft tissue. This figure shows the central squamous cell carcinoma of the bone beneath the second and third molar is extended to the retinomolar area and to the ramus is very big radiolucency. This figure shows a patch on the chest X-ray that lead to metastasis of oral malignancy to the chest. This figure shows the finger of the hand, and this have reduced the radio opacity of the bone and may lead some metastasis of tumor to the hand of bone. This figure shows the CT scan, three-dimensional CT scan. This figure shows the MRI figure of T2 and 1MO in the base of the tongue. Other investigation like hemoglobin examination, blood film, blood group are essential investigation. And lastly, a biopsy is essential to confirm the diagnosis and treatment according to histopathology of the lesion. The treatment of oral malignancy. The treatment goal to eradicate primary tumor and lymph node metastasis to maintain function, cosmetic reconstruction. The factor affecting choice of treatment depend mainly on tumor, patient, and resource factor. This factor, like general health, where in mouth or oropharynx is in the malignancy begin, the size of the tumor, whether the malignancy have any spread to other side of the oral cavity. There are three factors that affect on the treatment of oral malignancy. The first one, tumor factors and patient factors and physician factor. The tumor factor will have the size of the tumor, location, anterior versus posterior, proximity to the bone, status of cervical lymph node, previous treatment, tumor grade, depth and investigation. The patient factors like age, general medical condition, performance status, occupation, lifestyle like as smoking, drinking, socioeconomic consideration, and previous treatment. The physician factor like surgery, radiotherapy, chemotherapy, nursing and rehabilitation service, dental treatment, prosthetic treatment, and support services. The treatment goal for cancer of oral cavity, we have certain goal. First, cure of cancer, or preservative or restoration of form and function, or avoid or minimize sequel of treatment, and lastly, prevent second primary cancers. We have many policy for treatment of oral malignancy. We start first surgery, second radiation therapy, third chemotherapy, immunotherapy, gene therapy, and lastly combination of this treatment plan. We start the treatment choice, either surgery or radiotherapy or chemotherapy or immunotherapy or other type of treatment. We have stage 1 and stage 2 single modality treatment is effective and preferable. Stage 3 and stage 4 multi-modal therapy is essential. The treatment at first surgery. Early stage T1 and O or T1, 2 and O tumor wide excision plus minus lymph node, high risk of local regional recurrence about 40%. Management of an O neck, high incidence of acute metastasis in the clinically an O neck between 15 to 43%. Controversy, observation or surgery, radiation depend on primary side. Should we have minimal morbidity? L and D if risk of acute meta less than 20%, and SND or SOH and D. Locally advanced tumor combined modality treatment. The classification of lymph node metastasis neck dissection. There are two classifications. First one at 1991, that random neck dissection, modified random neck dissection, selective neck dissection as supraomohyoid, lateral, posterior, lateral, anterior, lateral, and the last one extended neck dissection. Other classification in 21 classification is random neck dissection, modified random neck dissection, selective neck dissection, like selective neck dissection L1, 3 to 4, other one 2 to 4, 2 to 5, and 6, and lastly extended neck dissection. This figure shows the selective neck dissection, and the have many type of selective neck dissection, and we have modified random neck dissection in type 1, type 2, or type 3. Standard treatment option for management of lymph node: radiation therapy alone or neck dissection in N1 between 0 to 2 cm. In N2B or N3, all need smaller than 2 cm. A combined surgical and radiation therapy approach should also be considered. Radiation therapy and neck dissection in N1, 2 to 3 cm, or N2A or N3. Surgery followed by radiation therapy, indication for which are as follows: multiple positive node, contralateral subclinical metastasis, invasion of tumor through the capsule of the lymph node, and N2B or N3, one or more nodes in each side of the neck as appropriate, less than 2 cm. Radiation therapy prior to surgery, large fixed node. The surgical approach, we have many approaches for surgery, like transoral approach, lower cheek approach, upper cheek approach, mandibulotomy, and Wizard's flap. The surgical approach depends on the tumor size, tumor acceleration, location, proximity to mandible or maxilla, need for neck dissection, need for reconstructive surgery. The surgical margin. There are safe margin when doing any surgery. This depends on the United Kingdom Royal College of Pathologists guideline that first clear margin histologically clearance less more than 5 mm, closed margin between 1 to 5 mm, positive margin is more than 1 mm. The incidence higher in oral cavity cancer than other human neck dissection, potentially due to complex anatomy and 3D of the head and neck. Factor predisposing positive margin. First, large tumor. Second, very neural spread, if any invasion to the nervous system. And third, vascular permission, if any vascularity within the tumor. And the other non-cohesive invasive wound. And the last one, cervical metastasis. The second policy is radiotherapy. This application is radical early tango from cancer and palliative advanced total control, not possible 20 gray plus 5 daily fraction and in 1 week. The combined therapy, preoperative radiotherapy and post-operative radiotherapy. There are the small T1, T2 superficial, less than 5 mm thickness lesion of the tongue and form interstitial brachytherapy does 60 days, 6 days within radium 192. Post-operative radiotherapy indication presence of nodal disease with extracapsular spread, presence on walled surgical margin, excision margin less than 5 mm, stage 3, stage 4, perineural or vascular invasion, poor differentiation, oral cavity primary, multicentric primary, less than 4 node positive, soft tissue invasion, dysplasia or carcinoma in situ at a resection margin. One type of the therapy treatment is immunotherapy. It is based on two principles. First principle, immune system should recognize and destroy abnormal cell. Second principle, tumor cell poorly immunogenic and strongly immune suppressive. The tumor down-regulate antigen presenting molecule PGE2 produced by tumor inhibit lymphocytic proliferation. Cytokine produced by tumor inhibit lymphocyte function. IL-2 interleukin 2 stimulate growth, differentiate, and survival of cytotoxic T cells. Systemic injection associated severe resection. Local injection in tumor, short half-life requiring frequent injection. IRX2 human cytokine mixture injected perilymphatically near tumor in a clinical trial. A trial of IRX2 in patients with squamous cell carcinoma of the head and neck had an et at Inter-Immune Pharmacology in 23. Using immunotherapy with 10 to 20 days of perilymphatic injections of natural cytokines mixture as NCM or IRX2 200 united interleukin 2 equivalents found significant reduction in tumor mass, increased area of leukocyte infiltration. Non-specific active immunomodulation, like Hpv vaccine, used to induce active non-specific stimulation of the immune system. The report of increased tumor-free survival, which could not be sustained. The trials with other vaccines, strep biogenes, the trypanosoma, prosi, levamisole, show no benefit in long-term survival. The other vaccine is Hpv vaccine. They estimate that 25 of the human squamous cell carcinoma in the head are HPV associated with 10 to arise in younger patients. Grade 1 and palatine tonsil occur predominantly in non-smoker drinker associated with more favorable prognosis. The HPV viral oncogene on E6 and E7 are constantly expressed in HPV-associated cancer through to integrate into the host DNA and when expressed bypass the regulation of cell proliferation. Both protein and DNA vaccine targets HPV DNA are currently in phase 1 and phase 2 trials. The other therapy is gene therapy. Is the gene therapy for oral squamous cell carcinoma and overview Tr. Saraswati, Indian and J. Dental Research. The strategies is according to gene addition therapy, reconstruction of wild type p53 function with p53 expression adenovirus lead to inhibition of squamous cell lines. Antisense RNA therapy introducing a remedial gene that prevents expression of a specific detection gene, potential target E6 and E7 gene of the human papilloma virus. Recurrent lips and oral cavity cancer. The surgery is preferred if radiation was used initially. Surgery, radiation, or combination of surgery used initially. Chemotherapy but not increase in survival demonstrated. Other novel therapy methods. The prognosis of oral malignancy is dependent on the location, thickness, depth of primary tumor, according to the staging of the tumor, type of histology and histopathology, the grading of the tumor, the presence of perineural spread, mandibular invasion, lymph node extension, level size extracapsular, molecular marker that if present. Thank you for your listening this lecture. Any question later for this